Isha, to screen sharing enable gardu no?
Hi, ma'am.
Okay. So shall I continue?
Yes, ma'am.
Sabazan aipugi? Have they come? Okay, now pelvic examination. Gynecology examination will not be complete without doing a internal examination, right? The exam, you don't need to do it, but you have to know the findings. It will be given to you. You have to ask for it. What is the findings in pelvic examination? So in pelvic examination, the uterus will be separate from the mass. A group may be felt between the uterus and the mass, and the movement of the mass per abdomen fails to move the cervix. That is also known as transmitted mobility will be absent if the mass is ovarian mass. Whereas if it is a uterine mass, when you move the cervix, the mass also moves, or when the mass is moved, the cervix also moves. The lower pole of the cyst may be felt through the fornix, and there might be absence of pulsation of the uterine vessels through the fornices. Now, this is the difference between the benign and malignant ovarian tumor. Benign tumors are mostly unilateral. Malignant tumors, most of the time, are bilateral. Benign tumors are mostly mobile. Malignant tumors are fixed. Benign tumors will have a cystic field, whereas malignant tumors will have solid or variegated field. What do you say? The field is either it is solid or variegated. And the benign ovarian tumors surface will be smooth, whereas in malignant it will be irregular. Ascites will be absent in benign ovarian tumor. It will be present in malignant ovarian tumors. But there are certain benign ovarian tumors like fibroma where ascites may be present and it is benign. But other than that, most of the time ascites is present when the ovarian tumor has transformed into malignant one. In benign ovarian tumors, the growth is slow, whereas in malignant, it is rapid. The most rapid malignant ovarian tumor is yolk sac tumor. Okay? The most rapidly growing malignant ovarian tumor?
Ma'am, yolk sac tumor.
Very good. So, benign tumors will be mostly seen in younger age group and malignant is mostly seen in older age group. When you palpate the pouch of Douglas, nodules will be absent, whereas in the malignant ones, there might be deposits, malignant deposits, and you might feel the nodules. Okay? Isma doubt saw. Can I proceed?
Yes, ma'am. Yes, ma'am, you can.
Now, what investigations would you like to do for a lady who presents with ovarian tumor? I have gone into more specific ones here, but you would proceed by saying, I would love to do blood tests like hemoglobin, PCV, platelet count, bleeding time, clotting time, because the patient will have to go for surgery. So I would like to prepare her for surgery in the meantime. Blood group RH typing, okay? Then after that, you would like to go for tumor markers like CA125, CA19.9, CEA, and alpha fetoprotein. So these are different tumor markers for ovarian tumors. CA125 It is mostly for serous cyst adenomas. See, 19.9 is for mucinous cyst adenoma. Action, no? Nita. Hello. Hello. She was. Okay. Okay. So the tumor markers like CA125, it is more specific. Nita, more class छु. त्यसलाई कोरोना पोजिटिभ छ अरे हैन उसलाई चाहिँ नि मेटफर्मिन 500 mg BD मा राखेर पठाइदिनु ल and call her back after 2 weeks है त fasting the PP okay ल thank you Nita ल bye okay अब म के भन्दै थिए C125 हैन C125 is more specific for serous cyst adenomas. CA19.9 is more specific for mucinous cyst adenomas, and there are CEA. CEA के को लागि specific होला त? CEA and alpha fetoprotein. Any guesses? Yuxac को लागि कुन चाहिँ? More specific. Alpha fetoprotein. Very good. I know. So those are the things. These are different proteins or markers that are raised in ovarian tumors. Tara, CA125 is not very specific because it can be raised in conditions like menstruation, if there are any kind of intestinal infections, in constipation, if the patient is pregnant, even it can be raised. But CA125 value, when it is very high, like thousands, then it is suggestive of malignancies. Okay, then you would go for other blood tests like LFT, RFT. If you're suspecting malignancy, then you have to rule out if the liver and the kidneys are affected. I know. This way, you would go for ultrasonography. In ultrasonography, you would like to see the site of the tumor, the size of the tumor, whether there is presence of ascites or not, okay? And whether it is bilateral and whether it is fluid-filled or it has solid components, okay? यहाँसम्म बुझिरहेको छ कि छैन?
Yes, ma'am.
Yes, ma'am.
सबैले बुझिरहेछ नि है? हेर्नुस् यो virtual क्लासमा है, because I am speaking, I don't know whether you people are there or not. कति गाह्रो छ कि त्यो छ नि उ गर्नलाई. So then you go for pelvic ultrasonography, and then to be more precise, you would like to go for MRI or CT scan. And त्यसमा चाहिँ you would like to see whether it has affected any other organs or whether there's lymph node enlargement. Okay. And then management, either it can be, if it's a benign tumor, you can go for laparoscopy. If you suspect malignancy, better to go for laparotomy. Now, what are the indications for surgery in ovarian tumor? Any solid ovarian tumor, you would like to go for surgery because the chances of being malignant or it being transformed into malignancy is higher. Any ovarian lesion with papillary projections into the cyst, that is suggestive of malignancy. So in that case, you would like to go for surgery. If the mass is more than 10 centimeter in diameter, then you would like to go for surgery. Or if it is a palpable mass in a post-menopausal woman or in a girl who has not yet attained menarche. So in those conditions, you would like to go for surgery. And if torsion or rupture is suspected, then you would go for surgery. So indications for surgery, ma ke doubts are. I would like one of you to repeat this because it's important. Sabaiलाई surgery गर्ने हो त? हैन. What are the indications of surgery? को छन्? म एकचोटि हेर्छु है त यहाँ को पार्टिसिपेन्ट्सहरु हुनुहुन्छ? झलनाथ.
Yes, ma'am.
ल बाबु एकचोटि रिपिट गर त ल. What are the indications for surgery?
Any solid ovarian lesion, any ovarian lesion with papillary vegetation on the cyst wall, any adnexal mass that is greater than 10 centimeter in diameter, palpable adnexal mass in premenarchal or postmenopausal women, torsion or rupture suspected.
Okay. So sabbaiलाई surgery गर्ने हैन. So if you see this kind of features, then you would go for surgery. So as I said earlier, it can be either laparoscopy or laparotomy. Whatever it is, you go for surgical exploration and pathological examination. So you explore it and then you send the tissue for pathological examination. Okay. The definitive management will depend on the type of neoplasm, the patient's age, and a desire for future childbearing. Benign ovarian neoplasms are generally treated by unilateral salpingo-oophorectomy, and contralateral ovary is carefully inspected, and sometimes we even take biopsy. And if the patient is very young and nulliparous, we mostly go for unilocular. And if the neoplasm is unilocular, we mostly go for cystectomy with the preservation of the ovary. And in older women, we go for total abdominal hysterectomy with bilateral salpingo-oophorectomy. Now, what is unilateral salpingo-oophorectomy? Your box with the JJ that is removed. That includes the tube and the ovary. Whereas the uterus, the cervix, it is spared. The other side, fallopian tube and the ovary is spared. Whereas in total abdominal hysterectomy, ke remove garcha ta? You remove the uterus, you remove the cervix, you remove the tubes bilaterally, and you remove the ovaries. Okay? Yes, no, bujeko ho haina.
Yes, ma'am.
Yes, ma'am.
Okay. Ovarian cystectomy, again, it is done for benign condition. You just remove the cyst. Now, malignancy like ke गर्ने ta? If there is ovarian malignancy, what do? You go for staging laparotomy. What do you do? Sabaijanale भन्नुस् त?
Staging laparoscopy.
Yes, staging laparotomy. अब त्यसमा के गर्छ त? Okay, त्यसमा के गर्छ? Patient would be under general anesthesia. You make a midline vertical incision. Sometimes you might even need to go above the umbilicus. Okay, this is mainly for better exposure. And what you do is, as soon as you open the abdomen, you remove the ascitic fluid and at least collect about 20 ml and send it for cytology to see for malignant cells. Okay, then after that, you start palpating the lower, the underneath of diaphragm. If there is any deposit, you scrape it and send it for pathological evaluation. Then you palpate the undersurface of liver, spleen, and also in the meantime, you see the omentum and the intestines. Then after that, you proceed with total abdominal hysterectomy with bilateral salpingo-oophorectomy with lymph node sampling and omentectomy. बुझ्नुभयो? Staging laparotomy मा के गर्दो रहेछ? You want me to repeat it, or one of you are going to repeat it? Who is going to repeat this? Whatever I just said, I want one of you to repeat because I want to be sure that you understood what is staging laparotomy. कसले repeat गर्ने? ल हेर, repeat गर्ने भन्ने बित्तिकै 3-4 जना गायब भइसक्नु भयो. हजुर.
Isma, the patient is kept under general anesthesia and a midline vertical incision is given, which can be extended up above the umbilicus if required. And once the incision has been made and the abdominal cavity has been opened, the first thing to do is to remove the ascitic fluid and send about 20 ml for cytology to check for malignant cells. And after that, the surgeon palpates beneath the diaphragm to check for any deposits, and if even deposits picture, they again send to check.
Yeah, scrapings are sent. Scrapings are sent for histopathological examination. Okay, and त्यसपछि?
And similarly, the surgeon will palpate beneath the liver and the spleen. Any deposits for scrapings are sent for histopathology. This the also checked for any kind of deposits. Along with that, a bilateral salpingo oophorectomy and a total abdominal hysterectomy is performed with lymph node
sampling. Lymph node sampling. The lymph node sampling भनेको के त? So you palpate for the different lymph nodes. And then if you realize or if you notice that it is enlarged, then you remove it. Otherwise, you do not remove it. Okay? And then you also go for omentectomy. ठिक छ? बुझेको हो सबैले?
Yes, ma'am.
Okay. Good. Then this is it. कसैलाई के सोध्नु छ? सोध्नु छ छैन?
छैन ma'am.
छैन? सबैले बुझ्नु भएको हो सबै?
Yes, ma'am.
Yes, ma'am.
Okay, then. राम्ररी पढ्नु है, revise गर्नु. You have recorded it, so revise it. And then if you revise it, I think you'll become clear. And if you do not understand anything, I'm always there. You can give me a call, then I can explain to you. Anyone. Right?
Yes, ma'am.
Okay then. Bye-bye. Happy weekend. Bye-bye.
Thank you, ma'am.
Thank you, ma'am.
Bye.
Thank you, ma'am.